It is. Okay, good morning, everybody. My name is Mandy Vessels. I am connecting to you from Empangeni in KwaZulu-Natal, and I'm one of the current members of the Child Health Priorities Association Executive. I'm going to be kickstarting the morning today with a lovely look at innovation all over the country. But before we do that, I just wanted to share a few housekeeping things for the rest of the program today. The first is that this session takes us through to 12 o'clock, but at 1 o'clock, we reconnect for the AGM of the Child Health Priorities Association, and we need to meet a quorum. So we ask you, please, delegates, to join back at 1 o'clock rather than wait until 2, so that we can vote in the new executive of the Child Health Priorities Association. And also, we need to plan for next year's conference. And if the delegates feel that it should be a face-to-face conference, at that time, we will also brainstorm and ask for volunteers to host it in your respective areas and run with the conference planning alongside the committee. So that will be there's obviously also financial parts of the AGM, but the two big things we really need quorum for are to vote for the new council and the conference for next year. So without further ado, I am going to launch into today while we just wait for more delegates to arrive. And I just wanted to reflect on what a fantastic day we had yesterday, exploring quality, cost-effective innovations for our children and in child health. And today we're going to have 8 speakers in this session who will share some of the initiatives that they have rolled out in their respective parts of the country. When I looked at the variety of innovative projects that people put forward, I was absolutely overwhelmed and so proud to be part of a healthcare network like this in the country. And it got me thinking about, how do people choose? What is the first step that they take to deciding what will be their next or what will be their first quality improvement initiative? We're all very good at quoting the PDSA cycle, and we're quite good at the doing, the studying, the acting. So today I just wanted to pause before we launch into these 8 projects and just look at the planning stage of a quality improvement initiative and look at what it is that we use to decide what to actually do next, and what do we use to guide us as to the next quality improvement project that we need to do. So yesterday, Dr. Amina Goga unpacked for us beautifully the concept of quality healthcare, and she reminded us how each of us are responsible for the quality of our own work in our area, rather than waiting for big policies and systemic change. To recap in bullet form, these are some of the large, broad pillars of quality healthcare: safety, never causing harm; effective care, evidence-based; people-centered, which Dr. Coetzee really unpacked beautifully and shared a video link to; timely, equitable, efficient. Prof. Saluji really took us through some amazing figures on efficient, cost-effective healthcare, and then integrated, which one of our speakers will touch on today, where the journey of a patient through the system should be consistent across the different healthcare workers. And when we look at the PDSA cycle, if you look at the document published by our national department, they talk about deciding on quality by checking yourself against the national core standards. This is a really robust and well thought out framework, but it can be a bit overwhelming to carry it around in your pocket. And we don't audit ourselves against the national core standards every single day. So then in that case, how do we decide? If we're managers in our area, how do we decide what should be our next project, or where do we get our information from to decide on the next step? It can be difficult, especially if you're in a new environment and you see 10 things you want to fix at once and you're not quite sure where to go from there and where to start. Whenever I have new managerial staff joining my team, I buy them a pretty notebook and I say, please write down everything you see at the beginning, because as you get started, you'll start to turn a blind eye to things that bothered you at the beginning, and keep a list running of quality improvement that you want to do along the way. So first, I like to divide the planning stage into 2 different types of quality improvement. The one being reactive. These are quality improvements that are derived out of something that's already gone wrong. And then there's proactive quality improvement, which is making a change before something goes wrong. And being a healthcare manager is striking a balance between these two. I'm going to a little bit into each of them and look at where the information comes from, these two different types of quality improvement. In reactive quality improvement, it's driven by necessity because something catastrophic has happened. And we get this from our patient safety incident reports, our patient complaints, our mortality data. We're very well versed in this. As South African clinicians, we're quite good at this. We can rattle off a fishbone or a 5Y as soon as we have to put a project in. And I think that in some ways, reactive quality improvement is easier because you don't have to advocate so hard. Something's already gone wrong. And because of that, management are expecting a plan. So they're eagerly awaiting it. And when you ask for funding and you ask for change, people jump at it because it's easy to see that something needs to be fixed when it's already been visibly broken. We also have to write them up quickly before the next PSI meeting. And so this type of quality improvement often takes priority. But the problem is when we only do reactive quality improvement, it feels like we're just plugging holes all the time. And we don't necessarily feel like we are moving forward. And it's a little bit of damage control and quite a demotivating way to do quality. So I want to reflect more on what most of our projects are today, and that is proactive quality improvement. One of my favorite authors, and I put this in inverted commas because it's actually a YouTube channel rather than written work, but Dr. Mike Evans has a series of YouTube videos exploring QI, and I've put the link at the bottom there. He talks about what you can do by next Tuesday, looking at this constant step of taking small steps forward all the time. And he quotes Dr. Don Berwick, the pediatrician who was instrumental in thinking about quality improvement. And he said, we should take our inspiration from toddlers. If they were just happy, or babies, if they were happy to just stay crawling, they would never learn to walk. But they have this constant natural curiosity to do better all the time. And when they're crawling, they're not worried about running the comrades when they're 30. They're worrying about getting up tomorrow. And that is what proactive quality improvement looks like. It's a small step forward all the time before things go wrong, making it quite different and a lot more positive. However, this type of work is more difficult in that it takes harder advocacy. It's hard to convince someone to change something and to get allies on board when things haven't gone wrong to prove that they need to change. You also have to try fit it in to schedule. And it's harder to fit something in when there isn't a crisis, whereas active quality improvement, a crisis has happened, so you have to put it on your list. These things tend to fall off the list and they tend to be a little harder. And then you have to balance as well. I put a little scale earlier, innovation fatigue in your team. So what really feeds into proactive quality improvement is data. Our data that we collect in so many forms and in so many different places, data for meaningful change. And it's often the first step in our proactive quality improvement, although we tend to think that data comes into the study part of the PDSA cycle when we've chosen an indicator to measure our projects. But in fact, it's our data that we collect daily that can feed into some fantastic quality improvement. Our numbers tell a story. They're essential for advocacy. Going into an advocacy project or quality improvement project without data is like going to war without ammunition. You need some numbers to prove why you need to make a change proactively. And we need to get comfortable with our data. What do we collect? Why? What else should we collect? And how can we add these to already existing tools? What do the trends mean? What stories do they tell? And you're going to hear a lot of that today from our panelists. So data for meaningful change, I've only thrown a few examples here, but we collect fantastic DHMIS data through our midnight stats and our facility information offices, child PIP, perinatal PIP, ICD-10 coding, which can feed into programs like EpiInfo, tell very good numerical stories, head counts at OPD, tell stories. And then we've got lots of qualitative data that we can fall back on. Chart audits, hand washing surveys, waiting time surveys, SAM audits, EPOC measurement against our national core standards are happening all the time. We tick them off, we submit them, but we need to analyze them to make meaningful change. And then, of course, there's patient-generated data. And unlike PSIs and complaints, there's a lot of meaningful suggestions that can come from listening to our people. Patient experience of care surveys, compliments, opening suggestion boxes. And then, of course, if your data is not telling what you want to know, you can add them. And I think some of our speakers will talk today about how they've had to come up with some of their own data collection tools or add them onto existing tools just to make them speak to their needs. And so in the sea of possible QIs that come up, how do you know what to prioritize in the planning stage? You want to find something that is compatible with organization and local culture, something that has technical merit that offers a significant advantage over local practice, and of course, the best fit for the most urgent problem at hand. So as I launch into introducing the speakers, which is next, I want to just remind you of the qualities you need to prepare in yourself in the planning phases. To be a change maker, to be an advocate for change, you need enthusiasm, optimism, perseverance, constant curiosity. Think of that little baby, and understanding of systems and their complexity, which Shweb shared with us yesterday. And then, of course, excellent relational skills to really listen and feel for your team when they have innovation fatigue so that you can time your quality improvement correctly. And today's speakers are all of those things. Our first three are going to be presenting on projects that are very data-driven. Our first speaker particularly is going to talk about collating the sea of data so that it can be used meaningfully and quickly by him as a manager. And then we're going to look at some speakers who have responded to the trends in their data or the gaps in their data. And in the second set of speakers, we're going to have a series of unrelated quality improvement projects that have come from patient-centeredness, evidence-based practice, and audit findings. So that is actually the end of my little introduction, and I'm going to stop sharing while Jeroen shares his screen, and I will then launch into introducing our first speaker. So Jeroen van Lobenstein is also on the north coast of KwaZulu-Natal, but slightly less rural than myself. He's from the Netherlands, and he moved to South Africa in 2004 after an exciting elective to Colophon Hospital in 1995. Jeroen worked at Witbank Hospital, then Gwelazan Hospital, and is now at Justice Zenga Regional Hospital, which is Stanger in KZN. He is the HCU of Paediatrics there. He is a CHIP coordinator for the province, and his keen interests are public health and the development and strengthening of clinical governance systems, which he will show us today. Over to you, Jeroen. Thank you.
Thank you so much, Mandy. That was a nice introduction. I'm going to move immediately because I've got a lot of slides. So this morning I'm going to share with you the tool that we developed to strengthen our clinical governance programs through an integration of routine and audit data. I've got no conflict of interest, and I'd like to start with a quote from Trevor Manuel that says, "If you can't measure it, you can't manage it." However, we know from the comic data that the quality that we gather in the Department of Health is often of very poor quality, and this impacts negatively on the health systems and child health in South Africa. So if you look at a ward level, the different the data tools that are there, there are multiple ones. Firstly, there's the district health information system that works with the midnight stats form and the daily and weekly service tools, and the admission book feeds into that. Then you have additional ward registers, HTS register, the transfer register, the infection register, the PMDCT register, and I probably have forgotten one, and already now I heard Mandy mentioning SAM. That's definitely another audit tool that we do. And then there's clinical governance systems, where we also, that also comes with their own requirements of audits and checklists. And then there's the national death audit review programs, Child PIP and PIP. In addition to this, there's also multiple performance review presentation requirements. So we need to make presentations for morbidity and mortality meetings, for clinical governance meetings, hospital information meeting, antibiotic stewardship meetings, and we need to feed into and populate the quarterly district operational plan. And of course, there's ad hoc meetings with managers if you try to advocate for change. So there's challenges. Because there's multiple data collection tools with no integration because of all our vertical programs. Then there's poor quality of data because most of our systems are paper-based and there's no built-in data verification tool at ward level, so staff is prone to make mistakes. There's also poor use of routine data at unit level, so the data flow normally goes upstream but doesn't come down to the staff in the ward. And there's duplication of work for all the reports that we need to submit. So we came up with a quality improvement plan that, and we designed a single digital tool that is based on routine DHIS data collection at midnight. And it integrates the collection, verification, and review of data and all clinical governance audits. It also incorporates a presentation format for the different review meetings and reports. And this tool was inspired on the Consolidated Death Report and the EPOC dashboard files developed by Ruth Davidge and Prof. McCarroll and KZN a few years ago. So the platform that we use is SharePoint. It's sort of a cloud-based system. It's available on the KZN DOH intranet, and it's accessible from every single DOH computer in the province. It allows selected staff members to have access to stored files, and those files are also extra protected via passwords. So our tool, the Clinical Governance Report, is based on 3 Excel-based files. So the first one is the main file, that's the Clinical Governance Report, and then we have a pediatric and a neonatal version. That file has 3 components. So there's a data component, an audit component, and a dashboard component. Into this file, there are 2 support files that feed into the CGR. Firstly is the daily DHIS data. So what we do there is the ward clerk captures on a daily basis the stats that we have submitted to the FIO, so the midnight stats. And the second support file is the FIO data verification file. So there the FIO enters at the end of the month the totals for the DHIS data, so we can verify that with our own data. So this is what the midnight stats form in KZN looks like. And this is then captured by the ward clerk into the daily DHIS file. And we have built-in cross-checks that I'll show you just now. So this is what it looks like, the file. So here you can see the daily data that is collected. It automatically tallies in weekly data and in monthly data. And the order there of all the data elements is exactly the same as on the midnight stats form. So entering of this data, it won't take a lot of time. At the bottom of this spreadsheet, you'll find these cross-checks. They're supposed to be all green because then you know that internal cross-checks between the different data elements, there were no errors. Here you can see on the 8th, though, the 8th of November, there was an error there. There's a mismatch. And you can then see on the left where the mismatch was. So here, the under 1 admissions, they don't tally with the different rate categories. And this is related to neonatal data, the neonatal CGR. This is what the FIO data verification looks like. So here the FIO enters selected data elements at the end of the month. And we have selected data elements that are related to the calculation of our case fertility rates and our in-hospital mortality rates and a few others. So then now the clinical governance report. Firstly, the data component. The data from both the support files is automatically drawn into the CGR. So that automatically arrives into the CGR and then facilitates easy verification of data. It also automatically generates the monthly tally sheet for a child PIP. It automatically generates presentations that we can use for mortality meetings. And it also calculates outcomes, case fertility rates. So this is what the data looks like that was first entered by the ward clerk into the DHIS tool. And this is now drawn into the CGR where we can access it and use it. And you can see it's tallies per month, per quarter, and per annum. This is a very important tool that we use at the end of the month because we verify the data. So here you can see in the first arrow in the black, that is our total data that we tallied ourselves on a daily basis in our own file in the ward. Then the second arrow, the red arrow, shows you the data that is collected on DHIS. And of course, that should be the same. If it's the same, we then populate the verified total column. But if there is a mismatch, then we need to investigate where the error is made, and then we need to correct it. The verified total, the data elements there, those are the ones that we use for our further calculations in the rest of the CGR. I mentioned already that the CGR also automatically generates the tally sheets, the monthly tally sheet that we need for the child PIP software. So there's nothing you need to do for it. You'll find it in the CGR, and it's also the order of the data elements is the same as used in the software for child PIP. The data component helps us with automatic presentations that we use in our different meetings. So this spreadsheet that you see here is automatically also populated by the spreadsheet, by the software. And then here you can see the monthly data that we use this data in our monthly meeting, mortality meeting. And here you see the key data elements that are useful for the junior staff to know. So how many separations were there, how many deaths were there, what was the average length of stay, and what was the bed occupancy rate. So the previous slide we do monthly, but quarterly we go a bit more in depth, looking not just at our output, but also at our outcomes. Again, this slide is also automatically generated by the CGR. And in the table, you can see the case and in-hospital mortality, fertility rates. And the graphs and bars are also automatically generated, and the graphs show the trends for the in-hospital mortality rates and the case fertility rates over a period of several years, while the bars show you the trends in the different quarters for this financial year. So this is the second part of that same spreadsheet where you see our different mortality rates. The second part of the CGR is the audit component. So here, all the death and all the other clinical audits that we do are captured in the CGR. And this facilitates, firstly, our mortality meetings, because the CGR also has a standard agenda. It captures all the action plans and ensure that we follow up on them. And there's also a robot system for that I'll show you just now. And it also generates the presentations that we use in those mortality audit meetings. The CGR also tallies key audit-related data elements that we then can quarterly review for trends. So here you can see the standard agenda that is in the CGR that we use. And here you can see action plans. So this is also a very important part of the tool. All the action plans are put in one single spreadsheet, and whenever they're entered in the different elements or in different areas, or if it's a dashboard related action plan, that we'll put it there. This is for data and this is for audit. Once the action plan is completed, you give it a green robot sign. If it's still outstanding, the robot sign will remain red till it is done. So in the beginning of a mortality meeting, we just go through all the different tasks, and we'll only stop at the ones that are red, and we'll do a follow-up on that pending action. Then the audits. For the audits, we have a monthly component and a quarterly component. So here you see the monthly component, where we make summaries, brief summaries of what transpired. Often you'll see that the ICU and the neonatal summaries are much longer. And then we also capture by quickly ticking, again, doesn't take a lot of time, by quickly ticking some data elements that we feel are important. So where the transfer was from, the place of death, the nutritional status, etc., etc. And that is automatically tallied at the bottom for each month. So this is what we do on a monthly basis. We put in the summaries there of what transpired, and we tick a few boxes. The totals are moved to the next table, and that is quarterly. So this table is automatically generated. And on a quarterly basis, we try to do a more in-depth review of our outcomes and our trends. You'll see the numbers in the table above. And lower down, we then we write down in words what the reasons are for our under 1, under 5 mortality rates and our case fertility rates. And that is especially very useful for the people in the district office, the program managers, because we used it to populate the DOP. So when it's time for the DOP, we copy this page and add it to the DOP for everyone to use. The second part of this quarterly review is the CHPA software. So we run the CHPA software quarterly, and then we complete this table for the modifiable factors and the top causes of death for the different age groups. So we don't only do mortality audits, we do many other audits, and they follow the same sequence of a monthly file and a quarterly spreadsheet. So I won't go into detail because there's no time for that, but here you see our PMTCT audits that we do with the quarterly review. Our NNE audits are kept it empty because that's more sensitive data that I didn't want to share. but we populate it also on a monthly basis, and then we review that on a quarterly basis, and we include there the audit scores from the obstetric audit, the neonatal audit, etc. A very other important audit that we do are our nosocomial infections, our hospital-acquired infections. Also there we complete this table with a small summary of what transpired and a few data elements that we capture. And here you can see again the quarterly overview. And it is we recently discovered, just by looking at the trends in these tables that are automatically generated again, that most of our infections, for instance, in the nursery were related to central lines, and this generated the action plan for a review of our central line practices. The last component of the CGR is the dashboard component. So in KZN, we have an essential package of care developed by Ruth Davidge and Prof. McCarrow a few years ago. That gives us a whole range of tools and checklists, and the whole aim is to develop a strong service platform with good quality of care, and this whole package is aligned with ID Hospital and the Office of Health Standards and Compliance. So here you can see the summary of all the audits that are done on a monthly basis. So the audits don't need to be done every month. There's an annual schedule for every single audit, and at the end of the month, you can see what your score was for that month. Then again, like we do with all our audits, quarterly we go a little bit more in and we look at our trends and see if additional action plans are needed. So, in conclusion, the use of routine DHIS data at ward level and the capturing of routine audit findings in a single digital spreadsheet has multiple benefits. It facilitates DHIS data verification. It improves local use of data. It allows for monitoring of trends relevant for the units. It removes duplication of work. It facilitates presentations of outcomes at audit meetings, and it assists with quarterly DOP submissions and takes away the need for additional reports when you give access to the CGR to your district pediatrician. So if people are interested, KZN, the 08 head office, Ruth has further developed the consolidated death reports and the data reports, and they are available online. If people want to develop their own tool, I'm of course more than happy to assist. But we must also watch the DHIS space, because the DHIS has an ability to do everything that I showed you today, plus much more. And this is maybe or should be our future all-in-one tool. Thank you so much, and a special thank you to Ruth Davidge, Pantegrau, and my consultant team for their bright ideas and support over the years.
Thank you very much, Jeroen. Every time I discuss this with you and see it, I'm blown away. Something that just goes in on the midnight stats can be pulled in via SharePoint, and it just does so much. And what you've really shown us is that with innovation, we can decrease our workload rather than increase it if you do the hard work early on. So absolutely fantastic. Thank you very much. We will take comments at the end of the first three speakers. So I'm going to ask Nontu, who has managed to connect, she was battling at the beginning, to just share her slides. And while she does that, I'm going to read her bio. You are welcome to post questions and comments in the chat so long, which Todeni is monitoring. Nontu, where have I lost my bios? I'm sorry. Nontu Mbatha is our chief dietitian at Queen Nandi Regional Hospital in Empangeni. She completed community service in 2011 in Mkhanyagude district, which is a rural district in KZN, famous for its very high percentage of children in the population. She has worked in 3 different districts in KZN. She has a master's in public health, and her special interest is in pediatric and adolescent health. Her focus now as a chief dietitian is on using data that is already being collected to maximize our resources and our potential. So with that introduction, I'm going to hand over to Nontu. We're very happy you managed to join us. Welcome. Nontu? Not here.
There you are. Was I muted there? Sorry. Just apologies. I may be a little bit anxious, especially after trying to run around and connect, but I'm glad that I finally was able to. As you can see, the topic of my presentation is geographical SAM data to provide a targeted intervention. I'm a firm believer that data is only as good as what you use it for. So we collect a lot of data in general in the health system, but I find that a lot of data we send off to somebody else at another level to actually intervene. But it's very little data that at facility level that we actually sit with and actually start looking at. And once you do that, you are able to do a lot more than what you think you can do. My screen is just stuck for a moment. There we go. Just a brief background. Here in KZN, we have what is known as the SAM database, where all SAM cases are entered into the SAM database at every facility each and every single month. Some of the information that is collected is demographic information, as well as a grant status. Is the child receiving a grant, not receiving a grant? Where was the patient actually referred from? Which is their local clinic? Because one of the things that we've picked up over the years is that children may be referred from a GP, they may be referred from a pharmacy, they may be referred from various other points to hospital level for management of malnutrition, but those areas are not necessarily their local clinic. So collecting the data on the local clinic itself is very, very important, as well as the underlying medical conditions, if applicable. This data is then usually sent off to our district office and our head office. But seldom do we actually sit down and analyze this data. So what I have done at Queen Nandi and my team has done is that we sit down and we analyze the data regularly to establish trends. We look at it on a monthly basis, we look at the data on a quarterly basis, and we look at the data as an overview on an annual basis. By doing this, we are able to actually monitor different patterns, and some patterns are noted and investigated for possible interventions in an effort not only to reduce our mortality, which everybody at all levels is always pushing for a lower mortality, but also to reduce our incidence of our severe acute malnutrition cases. So this is precisely what we have been doing. And what I'm going to present today is just one example how using this data actually has assisted us in making a targeted intervention, which has yielded positive results. So at the beginning of this year, my team and I sat down and we did some data analysis of our SAM database. We looked at a 4-month period, which was from February 2024 through to May 2024. In this period, along with our DHIS data, we looked at the fact that there were 30 SAM separations in our facility during that 4-month period. Out of the 30, we had 3 SAM deaths, which gave us a mortality rate of about 10% for our in-facility SAM mortalities. But when we zoomed in and really applied our minds in looking at the database, we noted that 6 out of the 30 separations were from one particular clinic, which was Mbonambi Clinic. And these children either came from the clinic itself, or that was their local clinic because they came to us via a GP or presented at POPD. Out of the mortalities of those 4 months, a staggering 20% of our, I beg your pardon, out of the incidents, 20% of these separations were from this particular clinic. This is not a very busy clinic. It is not our busiest clinic, but it's a clinic that actually has quite a big catchment area. Furthermore, we noted that 2 of our deaths were actually children who were referred from either Mbonambi Clinic or that Mbonambi Clinic was their closest clinic. So out of 3 deaths that we had in that 4-month period, 2 came from one particular clinic. So this actually made us ask ourselves, what is happening at this clinic if 20% of our incidents is actually from that single clinic, and 67% of our deaths in that 4-month period was from that clinic? So what did we do? We started a little mini investigation. We looked at our SAM deaths in depth. We photocopied the road to health cards of those SAM deaths, as well as looked at other children who were in the ward who were not necessarily SAMs, but had actually been referred from Bonambi Clinic. And some of the troublesome or the problematic areas that we noted was that all of these children had poor plotting of their weight for age, their weight for height, as well as their length for age. The children who were over 6 months didn't all have their MUAC done. And furthermore, there was poor assessment of the growth patterns in the children who had presented at the clinic more than once. There was also poor early nutrition support when growth faltering had presented to the clinic. So we noted that we needed to have a clinic intervention as soon as possible. However, as you may know, at Queen Nandi, we are a regional facility, and we do not actually support this actual PHC facility. But it didn't mean that we couldn't do anything. We just had to change our approach. My team and I and the Queen Nandi team, we couldn't get to that clinic ourselves. So we had to rope in other stakeholders. So who were the stakeholders that we actually roped in? Our intervention is that after we had found these findings in our Road to Health book, we communicated with the district nutrition coordinator, Mr. Mkhabele. The district coordinator met with the PHC coordinator, and they then visited Mbonambi Clinic to support the implementation of the recommendations we had put forth based on our audit and making and looking in depth into our Road to Health book. Universal MUAC screening for all children was emphasized, plotting and interpretation of growth for all children and infants. The nutritionist who actually periodically visits Mbonambi Clinic, what happened is that it was recommended that they visit more regularly in order to focus on the children who are NAMs at risk and present as a MAM. So that there can be early intervention with the provision of nutritional supplements as well as education as well. And the last intervention that we recommended was that if there are any complicated MAM cases or MAMs that were not improving on your integrated nutrition program supplements over a 3-month period, those patients were to be discussed with Queen Nandi for possible referral and intervention at a hospital level, not just a clinic level. Once we actually implemented all of these recommendations with the assistance of our district nutrition coordinator and PHC coordinator, we then evaluated the next 4-month period, which was from June 2024 to September 2024. According to our DHIS data, we had 18 separations in this period. Out of the 18 separations, we had 1 SAM death. Out of all the 18 separations, only 1 separation came from Bonambi Clinic. And that meant that it was a 5% separation rate. Furthermore, when I looked back at this particular case, we found that it is a case that was actually seen by the nutritionist at the clinic as a MAM. They came back, had deteriorated to be a SAM, and they were sent to us for admission and for management according to the WHO 10 steps. And one thing that was really great is that in the second 4-month period after the intervention, we had 0 SAM deaths from Mbonambi Clinic. So the takeaway message from us is that, you know, regular monitoring of data that you collect is really, really important. Not only just collect data and send it off to the powers that be or into the abyss where we don't know what it is used for, but to actually sit down as a team at a facility level to look at the data, interrogate the data, identify the relevant stakeholders is important when establishing an intervention. With this case, we couldn't physically get to the clinic due to the limitations of our catchment area as well as our hospital service package. But by collaborating with the district nutrition coordinator and providing them with suggestions of what interventions can be done, we were able to actually make an impact. Interventions need not be costly or time-consuming. Sometimes we feel that we need a lot of budget, we need a lot of money, we need a lot of resources to actually have an intervention. But sometimes our interventions are literally strengthening the current policy and the current practices that should be done and capacitating people who are in the position to do that well. Monitor your interventions for efficacy. It was important that after we had the intervention, that we then reviewed our data thereafter. And the data speaks for itself to say, not only did we have less patients who are coming from that particular clinic who presented with SAM, but also we had less deaths from that particular clinic. It's important to also evaluate for continuation or rethinking. So just because it has worked at one clinic does not mean we cannot use the same approach for other clinics. So we are continuing to monitor our data and looking at where our SAM cases are coming from, as well as where our MAM cases coming from now in order to prevent future SAMs. Data is good as what we do with it. So I encourage everybody, I always say, to look at your data, learn your data, know your data, so you are able to do interventions that are actually effective. Thank you.
Thank you very much, Nantu. There's something about people who love data. They're also very good at keeping to time. I'm very impressed with all the speakers so far. Nantu, it was a fantastic look at how just a snapshot of quarterly data could actually inform change. And the very next quarter, you were able to already see the impact of that change. And I saw it happen in front of me because I worked in the same area as you, but seeing it presented like this, just very powerful. So thank you again to the audience. Please do put questions on the chat. Tordeni is busy monitoring that. And Nantu, if you could stay connected for that question session, which will be shortly. Mareka, you are up next. Mareka tends to have to put her phone on the roof of the hospital to try and get good signal. So I hope we are good to go, but we did test it earlier. Let's see. There we go.
Cool.
Right, I'm going to then quickly introduce Mareka while you're sharing. Mareka is the physio and head of rehab at Manguzi Hospital in the far north of rural KwaZulu-Natal. She has spent 22 years at the rural coalface. She has a background in public health and a diploma in health economics, and was the previous chairperson of Rural Rehab South Africa. Those of you who know Mareka well or have worked with her will know that her passion is unmatched. So we are very excited to see one of your projects that you have rolled out. Thanks, Mareka. Go ahead.
Okay, morning everyone, and thanks for giving me the opportunity to share what we've learned over the last couple of years. I'm going to start without a veil with a story because I'm scared of my computer exploding. Baby X had a traumatic birth and was admitted in nursery for 2 weeks. He was seen daily by the rehab team and his mother received counseling. They were both admitted into the rehab department's high-risk baby program, which provides follow-up rehab screening services every 3 months at the mother's closest primary healthcare clinic to monitor the development and identify any potential problems. Baby X and his mom were eventually discharged from the hospital, but failed to arrive at their 3-month follow-up clinic date. This triggered a request for the community health workers in his area to trace him and his mother and try bring them back into care. The community health workers struggled to locate them. 6 months passed, during which repeated calls were made to try and trace the pair. Eventually, they arrived at the closest primary healthcare clinic on the OT day. Surprise. After assessing the child, the OT counseled the mother as she suspected that the child had CP. She referred them to the district hospital's weekly multidisciplinary pediatric clinic for further workup. They did not arrive for this appointment. Another 2 months passed, after which they arrived at the same primary healthcare clinic to see the OT again. At this point, it was decided that a working diagnosis of CP was going to have to be made, and the child needed specialized seating. The OT took measurements, placed the child on the posture support buggy waitlist, and fitted him into a customized APT box seat, which was secured into a basic folding frame wheelchair at the next clinic. After that, we never saw them again. And in 2018, this would have been the end of the story. We provided rehab services at district hospital and clinic level, and although our high-risk baby program utilized active surveillance, where a missed appointment triggers a track and trace response, our CP program did not. The onus always remained on the mothers to bring their children to clinic for care. Why should this story matter to you? I imagine many of us here today work in the public sector with its emphasis on expanding coverage and retention in care within an increasingly austere financial environment. With the NHI remaining on the agenda, perhaps you're thinking about contracting. Imagine you are being paid under capitation where you got a lump sum annually to provide a defined package of care to this defined CP population. Imagine your profit was determined not only through addressing efficiency and skills mix, but also through pay for performance where a bonus is paid if certain coverage, output, and outcome targets are met. A conventional approach to service delivery will not get you very far. Many of you may also be involved in the rising medical legal claims. Although these have undoubtedly brought CP and disability to the forefront for the first time, our inputs, service designs, and decisions made now have the potential to shape services well beyond the few who have successfully claimed and into the future. And all of this is, of course, within the context of the public sector, with its program silos, high staff turnover, fragmented health records, lack of end-user involvement in service design and delivery, and calendars of every single conceivable meeting except a case management one. In 2018, we provided group and individual rehab for patients with CP at hospital and primary clinic levels. Rehab services were well integrated into existing primary healthcare structures, although no home visits were provided for kids with CP. Although a rudimentary CP database had been kept over the years and had 72 names on it, some of them with contact details and clinical information, only 35 children regularly attended rehab. Posture support devices were provided to children on the waitlist and fitted by an appropriately trained seating specialist. Despite providing these services down to clinic level, attendance was haphazard, and children only received an average of 1 rehab session every 6 months. And once a wheelchair or buggy was issued, although you saw the child again, you never saw that buggy again, as mothers did not bring them to clinic due to the cost of transporting it. We had a 0% seating review rate. And then COVID hit with its hard and prolonged lockdown. After reducing our services to inpatient rehab for 3 weeks, it became evident that in order to prevent further disaster, we needed to shift our services for the most vulnerable clients to homestead level. This was no mean feat, especially as databases for separate services were housed on separate laptops and did not speak to one another. As we amalgamated them, the duplications, the previous missed opportunities, and the inefficiencies became very apparent. By the time we'd cleaned it up and added a risk rating to each client, we had over 400 names that needed urgent home visits. We needed another plan, and considering that each client required multiple professions and services at different frequencies of follow-up, we needed a better approach to data management. Excel was just not going to cut it for us. We set about redesigning our rehab health records electronically, pulling data from the client's profile and clinical entries into program dashboards linked to geographical areas. These clinic dashboards give our clinic teams real-time feedback on who's on track, who is overdue for follow-up care for services such as CP, wheelchair seating reviews, and home-based care. We also set about strengthening our local disability organization and training parent facilitators, as we needed more hands and ears at community level to act as early warning systems and assist in reinforcing rehab programs. Because this was COVID and there was extreme food insecurity, we also collected household data and the cost of a single round trip to clinic and to hospital with the child's buggy or wheelchair to enable us to raise funds for food parcels and advocate for a second outreach vehicle. The results were astronomical. Within a year, the new parent facilitators had traced and brought back into the system the majority of the 72 CPs on our original list. Within 2.5 years, we had 163 on our list. The sheer level of unmet need was astounding. Seating coverage and review rates rocketed. By shifting services to homestead level and adding a parent facilitator to the team, the psychosocial issues came to the fore. These are the issues that really affect follow-up rates and adherence to rehab programs. The real issues at home affected the goals that we had previously set and approaches going forward. The parent facilitators soon built up a strong network, with parents readily phoning them with the smallest concerns. Concerns that sometimes required our intervention and sometimes could be managed by the parent facilitator in the community. If you are still unconvinced from this data on decentralizing care, here's our attempt to calculate catastrophic health expenditure for 82 families with a child or adult with CP, where household, taxi, and welfare grant data had been collected. A lot of assumptions had to be made, and this is merely a proof of concept. But in continuing to offer rehab services at hospital and clinic level, 18% of households surveyed would have been pushed into catastrophic health spending within 8 months of adhering to rehab follow-up dates. If we only ran a hospital-based service, 49% of these households would have been pushed into catastrophic health spending. Do we really need more convincing? I'm not from the same culture, the same language, or the same socioeconomic group as the clients I'm providing services for. Some of my therapists are, but even then, none of us have a child with a disability. We may have the education and training, although the level of undergrad training in CP and seating is woefully inadequate, but we don't have the authenticity and we are less relatable. Parent facilitators also hold therapists to account and add a layer of sustainability to the system because they care deeply. But although we were patting ourselves on the back and telling ourselves what great rehab results these were, CP is more than just access to rehab. Unfortunately, convincing our other colleagues to join us on home visits was not such an easy task. Sitting down with them, we developed a screening tool together, a screening tool which could be implemented by parent facilitators and therapists at homestead level, and covered medical, dental, nutritional, socioeconomic, audio, and assisted device needs. Some basic in-service training was required, and the screening tool was added to our electronic health record to the patient's profile, and a dashboard showing real-time data on the proportion of CPs screened and the results was developed. 156 children and adults with CP were finally screened over a 6-month period by the rehab team. The results were a shocker, and thankfully bad enough to instantly galvanize our broader team of health professionals. But there was still hesitancy around home visits. Doctors took a lot of convincing to even walk outside the gate and see the 9 CP kids in the Disability Center for Chronic Prescriptions. Dental willingly extracted teeth in theatre if the patient arrived at hospital. Dietetics mobilized their nutritional advisors to trace the severe malnutritions we had picked up and bring them to clinic for a baseline dietetics consult. Thereafter, parents had to follow up monthly at clinics for supplements, but only needed to bring the child or adult in physically every 3rd month for a review. Speech and audio came out on home visits with me and did baseline assessments. But 6 months later, that was all that had been done. The follow-up data was collated and presented back to the broader team. Of the 41 malnutrition cases entered into the OSP program by the dietitians, 15 instantly defaulted. We know why. Of the 24 kids referred for extractions, only 6 arrived. We know why. But it's not just the cost to the client or the social support issues at home. Understanding data and using data to guide service delivery is not something inherent in healthcare professionals. Of the 41 clients referred for wax impaction fungal infections by the audio prior to being able to screen their hearing, none were followed up. Similar issues were observed in speech. Until we foster a culture of M&E amongst our healthcare professionals, the onus will remain on the patient to be their own case managers and follow up. Thankfully, we are a team that by and large really cares. So the 6-month data, impact data really hit hard, and I'm proud to say that we now have my medical manager, the dietitian, the speech therapist, and the audio committing to twice monthly home visits with a physio or OT and a parent facilitator to assist. This is not the final service delivery strategy. but we all need to be on the same page when it comes to decisions around service strategy and care plans. And this is where the home visits have been invaluable. Home visits have also assisted in linking the patients to clinics through the outreach team leader and community health workers who also accompany us on the visit. Home visits also provide a neutral and relaxed environment where we can all learn from one another and build trust. Trust in each other, critical in moving towards a transdisciplinary approach, trust in our end users as vital team members, trust in our own clinical skills and knowledge, and building trust at family and community level in the health system and team. From here, we can always reassess, reflect, and adjust. Let's go back to the original story about baby X. Baby X's posture support buggy arrived, and we tried calling the contact numbers several times to no avail. We decided to drive out 90 kilometers and trace the homestead based on the directions on the buggy prescription form. Finding the homestead abandoned, we tried calling the two numbers again. One went to voicemail, the other was answered by an aggressive male voice who claimed not to know the pair. We returned again the next week, house still abandoned. We hung around, we tried to knock at the neighbor's house. Although it was clear there was someone home, it took the lady a long time to come outside and greet us. She would not let us into her yard. When we asked about the mother and baby X's whereabouts, she bluntly told us they had moved. Eventually, she dropped her voice and said, if we drove to a high school 20 kilometers away and asked around, we might find them. We drove there. No one knew them. It took us 2 hours to find their house. Baby X's mother had been in a stable relationship and had 4 kids with the same father. One day she woke up to find he had paid lobola for the neighbor. He kicked them out. The mother had no ID papers, and the 4 children, including baby X, had no birth certificates. Whilst the school at the original homestead had allowed the 3 older kids to attend school without papers, the new area did not. Baby X's mother, to whom she had moved back to, also had no papers and earned a few rands plowing for other people, even though she was around 80 years old. Although baby X was in remarkably good shape, thankfully he did not have a low EDAX, any trip to the clinic was now a 10-kilometer walk each way, as there was no money for transport. Although we issued him a brand new buggy and customized it for him, this is now the least of the family's concerns. Thankfully, by finding them, they are now linked to the municipal councillor and the full MDT hospital team. They also now receive food parcels from the faith-based organization, regular home visits from the parent facilitator and the rehab team. Until we change the way we design and deliver care, the inequalities in our system will remain. Thank you.
Wow, Mareka, thank you. I think the quote for me for the morning is, the results were astounding and allowed us to galvanize our team, and that's precisely what we wanted to show. Exceptional use of data and advocacy work. Thank you. We are having just 2 minutes, in fact, between the 2 sessions to have a look at the questions. Arun said to Jeroen, very impressive. Can you comment on how many people are involved in the collation of that fantastic SharePoint document and the time required per week or per month to actually pull something like that together that was aimed at Jeroen?
Would you like me to answer, Mandy?
Yeah, please. We've got a minute.
Okay. Yeah. So it depends. So what we normally do is we work per quarter. So one consultant is allocated per quarter to populate, because then it's easy to follow up on pending matters from the previous month, because you know. So generally, one consultant per quarter is involved in putting the data on the CGR. If it all depends, I mean, this is just one little part of the entire clinical governance program that you have, and about data verification of data. And so if the data is verified on a daily basis at unit level, then at the end of the month, there will not be queries. So then the data verification doesn't take a lot of time. The audits are done anyway, and the entering of the data into the tables of the audits does only take a few minutes per case. And then the ward clerks, they do the bulk of the work actually by entering it daily, but even that, it takes about 15 minutes on a daily basis to enter the data.
Okay, Thanks. That's really helpful for us if we want to try replicate it elsewhere. Just looking at the time, I'm not sure that we're going to be able to read out more questions because we've got 5 speakers in the following hour. So I'm going to ask Nothando from the next session, Nothando Mbatha, if you can share your presentation so long, and then to just ask Mareka and Nontu. There were questions for you on the chat. Nontu, there was one about your numbers of SAMs and the frequency of them throughout the year, or if they sort of in seasonal waves. And Mareka, there were some questions lower down about task shifting, the model that you've just described. If it's possible to put your answers in the chat for everybody, then that will save us some time. And thank you to the first 3 data champions, I can call you, for your amazing presentations. I'm going to introduce Nothando now. Let me just get my ducks in a row. Apologies. Nothando Mbatha holds a PhD. She works in the public sector on the nutrition programs in the community, including school nutrition. Her research and academic focus was on the school health program, looking at schools as a setting for health promotion activities. So lovely. We're going to be shifting away from the hospital and looking at the schools. Without further ado, Nothando, please go ahead. Thank you.
Thank you. Yeah, like Mandy has said, hi everyone, that my work focuses more on school health in our community, especially around Tshwane. So what I'm going to be presenting today is research we did with my colleagues from the University of Pretoria, looking at a school health program, which is part of the policy by DBE. So it's perceptions and views of key implementers on the implementation of the health promoting school program in the City of Tshwane, South Africa. So it was published in the SMJ. So my work looks at older children in primary school especially, and we look at health promotion using school health policy interventions to check and evaluate if they're being implemented as intended by government. So with health promotion, the definition that is, it's a universal definition, the Ottawa Charter, is health promotion is the process of enabling people to increase control and improve their health. So what we try to do with our research in schools is to try and improve, enable teachers and even primary school learners to be able to increase their control over their health, make better decisions, make informed decisions. So just a brief background is non-communicable diseases are on the rise in South Africa, including among children, unfortunately, and the youth. We're seeing a lot of obesity, a lot of diabetes in young people, and a lot of hypertension and other chronic diseases from lifestyle. So traditionally, schools focused only on teaching and learning. They ignored the social and physical factors within and outside the schools that actually affect the well-being of learners. So World Health Organization introduced a whole school approach, which is a holistic approach to health promotion as a possible solution to poor health outcomes in school going age children. So we see that it's a whole school approach because it looks at every facet of the school. It looks at the curriculum, the teaching and learning. It looks at the school organization, the ethos, the culture of the school, and the environment, which would be your physical environment so that kids have space to play and be physical. It looks at your nutrition environment so that kids are actually able to make better decisions. It looks at your vendors. It looks at the school feeding scheme. And it looks at also partnerships and services, like how schools have a relationship with outside people, the business, municipality, and whoever can contribute to the school. And we found that schools that have a good relationship and partnership with outside services like businesses are able to actually supplement even the diet of the school. They're actually able to help even children who don't have anything at home. They bring them food so that they take home. So not only feeding the child, but also feeding families. And with the curriculum, health promotion is taught within the curriculum. It's not something that is outside, which is good because then there's no extra work for the teachers. It's part of the curriculum. So whole school approaches, there's a lot of evidence showing that the holistic approach to health promotion can improve body composition, healthy eating, physical activity, fitness, and positive mental health outcomes in learners. So in South Africa, health promotion is done in the life skills module or even the life orientation module. So topics that are normally covered will be nutrition, hygiene, sexual education, emotional intelligence, bullying, and so forth. And also PE, because they have a section where they do physical education. So our study aim was to use grounded theory methods to explore barriers and facilitators to the implementation of the school health policy in Tshwane schools by interrogating the views and perspectives of health and education staff. So we sampled our initial sampling. We started off with purposive sampling, and we had 5 educators. These are only life skills educators because that's where they're supposed to do health education. We had 3 principals and SGB. We had to include the SGB because any plan, any policy that the SGB does not buy into will not succeed in any school. They are the ones who adapt plans. They are the ones who prioritize plans. So if they don't prioritize health education or any health promotion activities, then it will never be done in the schools. So after initial analysis, because we're doing grounded theory, we did theoretical sampling because we found that LO teachers sometimes didn't know what they were supposed to do. So we even had to go to other teachers who were in charge of health activities in the school. So after theoretical sampling, we found 8 other participants. So in total, we had 20 participants, interviews, and focus group. So our findings, what we found was that our core category, what the basis of everything for health promotion to be successful in school was guidance and accountability for policy implementation, which will come from the district, from province, and from national. That was lacking. Nobody was accountable for anything, and nobody was held accountable for anything. So implementation was based on the principals' feelings. If they liked the program, they would implement. If they didn't, they would not implement. And we found that there were other 5 categories for implementation, which was number 1, preparation was key. We found that all the participants said before they bring the policies into the schools, government should have a first phase of just preparing the school for this, looking at resources, actually getting buy-in from communities, from parents, and from everyone, where you just prepare. Everyone is going to be involved for the program. There needs to be continuous training. The LO teachers or the life skills teachers were not trained in anything they had to do. Some of them were complaining that they're supposed to teach about nutrition. They actually don't know much about nutrition. They just read what's on the curriculum, but could not expand. And they, even for the PE, they complain that they don't know what to do with the kids. And PE is supposed to be structured because it's supposed to actually bring out things from the kids. They're supposed to learn from it, but it didn't because they didn't know what they were supposed to do. Even with arts, they didn't know how to draw. They'd never been trained. Most of them complained that they'd been taken from another class and brought to life skills because there was a shortage, so they were not skilled. Achieve teamwork. Also, this is a collaborative effort, so everybody needs to come on board. So there needs to be work between DBE and the Department of Health, not work in silos. All departments need to be brought in. External academics, everybody needs to be part of the program, and it was lacking in Tshwane. Address implementation barriers like lack of resources, nobody cared, and also things like unsupportive nutrition environments. Kids were taught about nutrition in class, but when they go outside, vendors are everywhere who are selling things that are not healthy, chips and things like that. And also educators complain that the food they buy from the vendors actually disrupted teaching and learning because when they came in, they'll be hyperactive in the morning after eating sweets, and some of them would vomit. And this was even before the time of the food poisoning we're seeing. So they will vomit in class and it just disrupted teaching and learning. So they would want it to stop, but the problem was that the vendors were actually paying some sort of stipend to the school. So teachers could not stop them because the stipend helped to actually do some things that the school wanted. So we need government to come in and actually regulate this because currently there's no regulation. Schools decide what they want to do with the vendors. And then lastly, everybody complained, all participants said there needs to be evaluation and they need to be told what they're supposed to do and if what they're doing is okay or if there are gaps. So government needs to come in and bring in academics and bring in anyone who's part of the stakeholders to actually be part of the implementation program, facilitate sustainability. Because sometimes when you get a good principal who actually implements the program, when they retire or move to another school, then the program fails because there's no sustainability plan, there's no succession plan. So those were the problems that were found. And so just to conclude, the stakes are high. access to supportive school environments in health promoting schools has reduced dropouts. And even in South Africa, even as we did the study, we did a prior study before doing this one, an evaluation. We found that the educators and the parents said that if it's implemented well, it was actually able to help with dropout, and that the children were able to be retained in the school, and that parents looked after the schools, and that they came in to help with the food gardens so that the kids could eat. They were able to do a lot of things if it's done very well. It also improved educational outcomes, employment, and productivity in settings where it's implemented well. So we found that in court, it was found to be weak. Implementation was very weak, leaving many learners in these schools in a vulnerable position. And we need to improve, especially with the situation that's happening with kids and poor educational outcomes. If these policies are not implemented as they're supposed to be, then we're just going to have more problems, and our kids will not be as productive as they should be in the future. And with that, thank you. I'm done.
Thank you very much, Nothando. I think Mareka's quote from earlier, "I've never wasted a good crisis," just makes me think that the current crisis with school vendors is such a powerful time to pitch your advocacy work that you've done in this regard, specifically about the vendors. Of course, your project was about more than that, but it's really under the spotlight at the moment. And so we thank you for sharing this with us. It's such a cross-sectoral involvement in quality improvement is so important in pediatrics, and I think you've really hit the nail on the head with how much we can do with the schools. So I ask again everybody to please post their questions to Nothando in the chat while Shakti Pillay loads her presentation. She is up next, and then I will introduce the next speaker. Thank you very much, Nothando. If you want to keep an eye on the chat for your questions. Dr. Shakti Pillay is a neonatologist at Groote Schuur Hospital. She's been working there as a neonatologist since 2019. Her research focuses on congenital infections, neonatal neurology, and therapeutic hypothermia in low-resource settings. She is the University of Cape Town site co-principal investigator for the NESHI study on neonatal encephalopathy. She's passionate about governance, ethics, and digital health. Shakti designed, developed, and co-authored the Neonatal Guide app and is a lead author for the 2023 South African Department of Health Maternal and Neonatal Guidelines. So very well versed in sharing this topic of digital doctors resources with us. Thank you. Go ahead, Shakti.
Well, thanks, Mandy. So good morning. Today I will share how we at Groote Schuur Hospital Neonatal Unit are using technology and digital platforms to optimize orientation resources, unit protocols, and administrative processes. These innovations provide real-time access to critical neonatal information while supporting sustainability through eco-friendly and inclusive solutions. Our goal is to equip clinicians with the tools that they need to deliver high-quality care in a fast-paced and evolving healthcare environment. Our transition to a digital platform is driven by the evolving demands of modern healthcare. Today's digital doctors thrive in tech-enhanced environments and require tools that meet their fluency and expectations. Simultaneously, the rapid growth of medical knowledge makes it impossible for clinicians to stay fully up to date without real-time, precise, and accessible solutions. In neonatology, where clinicians face high pressure, dynamic problem-solving scenarios, frequent staff turnover further complicates care. With multiple tiers of staff rotating frequently, a reliable, protocol-driven system is essential to ensure safe and effective practice for all team members, regardless of experience. Real-time accessible resources empower clinicians to act with confidence and accuracy, meeting the demands of this challenging environment while reducing risk. Furthermore, this transition to a paperless system aligns with sustainability goals, reducing waste and embracing environmentally responsive practices. By integrating digital tools, we aim to improve care quality and contribute to a sustainable future in healthcare. So to support our digital transition, we explored platforms that met our core criteria: simplicity, cost-effectiveness, and inclusivity. We tested accessibility by using the least technologically inclined person in the department to ensure that the platforms were user-friendly and intuitive. We avoided coding-based platforms that could introduce unnecessary complexity. Our goal was to create a common landing page with seamless links to essential documents stored on free, reliable platforms without storage limitations. We ensured compliance with legal frameworks such as the POPI Act and enabled quick access without multiple logins or complex security settings. Based on these criteria, we selected 3 platforms: Dropbox for secure storage and unlimited sharing, Microsoft Sway for creating dynamic interactive resources, and Canva for visually engaging educational materials. Together, these tools have helped us build a streamlined, accessible, and scalable system that addresses the diverse needs of our neonatal team. Now, let me demonstrate how we have integrated these platforms into our unit's workflow to optimize learning, governance, and efficiency. So Microsoft Sway has been a transformative tool in centralizing our critical resources, including unit protocols, governance documents, and administrative workflows into a single accessible platform. It is a coding-free Microsoft app that works seamlessly across mobile devices, iPads, and desktops, making it both cost-effective and inclusive for our team. Its design is user-friendly and visually appealing, enabling intuitive navigation through clickable links and ensuring that content remains relevant with regular update based on staff feedback. To make accessibility even more seamless, Sway can be added as an icon directly on mobile device home screens, functioning very much like an app, as seen in the image on the far right of the slide. We have also embedded the Sway link in our staff WhatsApp groups, allowing quick access without the need for time-consuming searches. This ensures that resources are always just a tap away, which is crucial in a fast-paced environment like neonatology. While Sway requires an active internet connection updates, we have addressed this by ensuring Wi-Fi is arranged for all new staff before they start. And another challenge we overcame is Sway's need for a UCT email for security purposes. We resolved this by organizing third-party UCT email accounts for staff who did not already have one, ensuring full access for every team member. Additionally, I've integrated Sway training into the onboarding and orientation processes to ensure staff are confident in its use and can maximize its benefits. Here on the screen highlights how Sway is specifically tailored to tackle challenges faced by junior doctors and rotating staff, such as navigating governance protocols, assessing orientation materials, and managing administrative tasks. By addressing these needs, Sway empowers clinicians to work confidently and efficiently, even in the high-pressure setting of neonatology. So let me just take you through a specific section of our Microsoft Sway webpage designed to enhance accessibility and provide robust support for our team. So as you'll see, the content is visually organized into sections, offering a clean, user-friendly layout that makes navigation straightforward. The interactive design integrates videos, images, and clickable links, which lead directly to essential resources securely stored in Dropbox. So a key feature I'd like to highlight is the small gray icon located at the bottom right of the screen. This menu facilitates quick navigation between sections, eliminating the need to scroll through the entire document. So if you're looking for orientation documents, you can simply click on the menu, select the relevant section, and be taken directly to the information you need, as demonstrated in this video. So the structure of the Sway platform ensures that all resources are not only easily accessible, but also organized in a way that significantly reduces the time spent searching for information. By streamlining access, it allows our team to focus their efforts on delivering high-quality patient care while enhancing their learning experience and promoting overall mental well-being. When staff feel supported, they are empowered to perform confidently and effectively, fostering a collaborative and efficient work environment. So while Microsoft Sway serves as our primary hub for clinical protocols and governance, Canva provides an alternative platform tailored to support staff well-being, development, and mentorship. With its visibly engaging and intuitive layout, Canva focuses on the human aspects of our work environment. It's easy to access without requiring logins, and its interactive features make navigation simple and efficient. Together, these platforms ensure we balance operational efficiency with personal support, creating a comprehensive digital ecosystem for our team. So our Canva-based websites play a key role in fostering collaboration and supporting research within the department. The BioSketch platform enhances mentorship and interpersonal connections, ensuring staff and students can connect academically. Additionally, the MMed and MPhil websites serve as a dedicated space for research support, providing tools and resources tailored to the needs of registrars and postgraduate students. Both platforms are visually engaging, easy to navigate, and regularly updated to remain relevant to users' evolving requirements. The Neonatal Guide app is an in-house innovation at Procedural, specifically designed to provide up-to-date evidence-based neonatal care. Transitioning from a traditional book format to a dynamic app reflects our commitment to adapting to changing times and embracing digital transformation. While its development required more complexity compared to other digital resources, it demonstrates that such innovation is both achievable and sustainable with the right motivation and governance. This app provides quick offline access to evidence-based guidelines and protocols, making it an indispensable tool for bedside care and staff training. It complements our broader digital resources by enhancing efficiency, improving patient outcomes, and empowering staff. While we have received positive feedback through the app stores, we plan to formally evaluate its impact together with our other digital resources through a retrospective survey of our junior staff. This assessment will hopefully inform and guide future updates, ensuring all our digital resources continue to meet the evolving needs of our team and support our goal of delivering exceptional neonatal care. So in conclusion, at Procedural, our journey into digital innovation has proven that meaningful change is achievable with dedication and vision. By starting small and focusing on practical evidence-based goals, we've built a foundation that has transformed how we work and empowered our teams to deliver better care. Success in digital transformation requires more than just tools. It needs one dedicated person to champion the change, sustain motivation, and ensure governance aligns with the vision. Collaboration and feedback are also key. Motivated teams have shown that innovation isn't just possible, it's impactful and sustainable. And with teamwork and commitment to learning, and with someone leading the charge, we believe that anyone can learn anything from anyone at any time. And this mindset drives us forward. Thanks.
Wow, Shakti, thank you. That was absolutely inspirational. I've never actually seen Canva used in that way, just to make birthday party invites. So mind-blowing to see what you can do with things that are already available. I'm curious to know how you selected the least technologically minded person to test it on, but really very, very inspiring, and it seems like something that's very reproducible elsewhere. And we all love the purple book that became the purple app, so thank you for that innovation. I'm going to ask Prasha, I've moved the order slightly because she has another meeting. Prasha, if you can load your talk so long while I introduce you. Let me just open up my... Prasha Doorgapersad is a pediatrician at Prince Mshiyeni Memorial Hospital, which is a 1,075-bedded regional hospital in Durban. She's got a keen interest in child health and has completed her postgrad diploma in pediatrics and community health in 2022 from UCT. She is passionate about quality improvement and is keen to share this experience that recently saw her winning quality improvement awards in the province. Please do go ahead, Prasha. You are most welcome.
Thank you very much, Mandy. Thank you for that intro. And I'm very happy and thankful that we have this platform to share our procedural pain QIP done at Prince Mshiyeni Hospital. So just quickly, no conflict of interest to declare, and I'll jump straight into it. Why did we choose this topic? And as Mandy had described earlier, this was a reactive quality improvement program though. So we had a patient safety incident where the separation of a mom and baby during an IV line insertion resulted in a fall. And when we looked at the root cause analysis for the safety incident, apart from several other factors, mom and baby being separated was a key factor in this child's, in the safety incident and the fall. This also resulted in a complaint. So quickly, what is procedural pain? Essentially, it is any pain that a child experiences during a medical procedure that we do, both as doctors and nurses. So we often think of big procedures like IC drains causing pain, but remember something small like glucose monitoring, a heel prick, inserting a nasogastric tube is a painful procedure. There was a study done at Gray's Hospital here in KZN where children and caregivers reported that the worst pain they experienced was from needles. And this was way above the surgery they had or any other medical procedure that had been performed on them. So how do we treat procedural pain? We've got clear guidelines. The standard treatment guidelines tell us what to do As you can see, they highlight a safe environment. They also talk about pharmacological and non-pharmacological measures, and the use of EMLA cream and sucrose solution are key factors or key drugs to use in procedural pain. But despite having guidelines available, many children don't receive procedural pain relief. And when you search the literature, you'll find that this is a worldwide trend or phenomenon. So anything from 0 to 70% to 80% of children receive procedural pain management, depending on where you are. When pain is poorly managed, there are several knock-on effects, which may be immediate, like the safety incident, or even a healthcare worker having a needle stick injury, but also long-term issues like pain processing pathways are affected. Adults eventually develop needle fears, which may impact their later health-seeking behavior. So from this point, we started our QIP journey this year on the 23rd of May, and it lasted just over 4 months. So this is a quick overview of our methodology at each phase of our project. So for our situational analysis after the PSI, we did observation, survey, and audit, and we walked around our wards, looked at practice, and noticed actually all the mums were sitting outside the procedure room. Babies were inside, they were crying, they were fighting, and most often did not receive any kind of analgesia. We then proceeded to do a survey. We wanted to know what our healthcare workers knew about pain, and particularly procedural pain, and what their practice was. And we sent out a document on Google Docs. Rather, we designed a document on Google Docs and sent it out on WhatsApp to both doctors and nurses. And when we analyzed the results, only 27% of our healthcare workers, both doctors and nurses, noted that they were giving any kind of procedural pain analgesia. And the next step was we wanted to audit procedures and directly see what was happening. We audited 40 procedures and very, very unfortunately found that only 5% of procedures audited did any child receive procedural pain analgesia. So we realized we had a problem. And just quickly, the root cause analysis was done with a fishbone and 5 whys. And our quality improvement methodology was the PDSA cycle. So I've gone through this already, but just a summary, we had a problem of poor procedural pain management in our department. Our root cause analysis identified a few factors that we wanted to address. So doctors were telling us they forgot to give analgesia when we did a survey. So that was something we thought we needed to address. But there was also quite a big lack of knowledge about procedural pain, both from the healthcare worker and from the caregivers. Our doctors and nurses had poor pain assessment skills. And on a system side, we had no policy in our department for pain management. And also the staff were telling us that they didn't have appropriate drugs in the ward. But when we broke this down even further with the 5 whys, it actually came back down still to a lack of awareness and knowledge about pain, which is why they were not ordering the drugs and why pharmacy did not have the stock available. Well, so we set about our aim. We wanted to increase the number of children receiving procedural pain management in our department by 30% above our baseline for pharmacological pain relief. We were also going to monitor non-pharmacological measures, and we wanted this improvement to impact our patient experience of care and improve safety. So these were our change ideas and solutions that we were looking at. And because there was such a huge no-to-do gap, so knowing what to do, we have the SDGs and actually doing it, we deliberately sought out knowledge translation strategies. So strategies that were proven to have high impact and cause a change in behavior. So the ones I've highlighted here are reminders, huddles, and audit and feedback. And I'll tell you a little bit about this. So these were our outcome measures. We were going to measure the percentage of children who had a procedure performed, who received pharmacological pain relief. We also were going to look at non-pharmacological measures and also patient interviews to determine their satisfaction. Our process measures were per strategy, and I won't spend too much of time on that. So initially, reducing the knowledge gap. This was one of the strategies we wanted to employ because we thought huddles or small group interactive teaching would improve the uptake of knowledge and change practice. So a huddle, we called it a huddle because it's a terminology I came across when doing a literature search for small group teaching. So we did short sessions. Bite-sized chunks of information were given to our staff, and we tried to keep it at most to 15 minutes so as not to interfere with their work and to also keep them engaged. We did this in 4 clinical areas in our department. NICU was excluded. So there were 4 simultaneous huddles led by a doctor on the QIP team done in our clinical areas. Doctors and nurses were our audience, and we designed 3 designated teaching topics, which were shared with staff prior to the teaching. We held sessions on a Monday and Friday. So Monday, we introduced a teaching topic, and then during the week, the staff implemented what they learned. They put it into practice, and on Friday, we came back and did a Q&A session with some feedback and looked at troubleshooting and also just reminders during the huddle session. Some of the questions that came out of the Q&A session were simple things that we hadn't even considered. So the nurses were worried about giving sucrose to the babies because the GMs would increase. And we had to address all of their questions and encourage them to move forward and to use the drugs as they were available. We also had problems with rotating staff, so we had to repeat huddles as well. So this was quite a key strategy for us because we felt that the feedback session was what helped staff assimilate the knowledge after putting it into practice during the week, and hopefully this would change their behavior. These were the designated teaching topics. So in the first week, we talked about needle pain because that was the worst pain that kids reported. But also we looked at non-pharmacological methods of pain management and also how to assess pain. Just remember, children don't always tell us they have pain. Babies are pre-verbal. We have children with cerebral palsy. So pain assessment skills do have to be quite good in our staff. As you can see, for every teaching session, we did emphasize the role of the family and the caregiver and how important they were during the procedure and all pain assessments. We also put together a bank of distraction videos. So for the non-pharmacological methods, we found that using videos was a very easy way for our staff. Everyone had a cell phone. So we gathered videos, put them into a bank and shared them with our staff. So I think my time is almost up. So I'm just going to quickly, we also created a Dropbox folder for our resources and shared a QR code for an easy link. There's reminders, these were our reminders. So point of care and bright yellow reminders. So hopefully nobody would forget. And then audit and feedback was another method we introduced, which I think the feedback session was quite important. I'm going to jump quickly to results. As you can see, we monitored EMLA. By this, we wanted to decide if our staff were using the drugs, and you can see the trend has shown an increase, and the same with sucrose. And our final outcome measures, we had gone from 5% for pharmacological measures to 63% at the end of our QIP. So our patients and our stakeholders were very happy, and a lot of doctors felt empowered. So we felt that we had achieved our aim. And just to keep the project going, we put out an exit plan. And as you can see, just covered quite a few ways to ensure the ongoing ongoing teaching of the project. So I'll end there. Thank you very much for listening, and to everyone who helped with our QIP.
Thank you so much, Prasha. A very inspiring work. I particularly like the exit plan because sometimes when we've rolled out a reactive QIP, it sort of feels like we've ticked a box, but it's fantastic to see your efforts to make it sustainable and to continue it in the process. I also really like the QR code idea. Instead of searching through your phone for links and opening things, it's a really, really fantastic idea. So very well done to your team at Prince M. Again, I'm going to ask for anybody to put questions for Prasha on the chat, though she does have to duck away in a few minutes. And I'm going to ask Zandile Kubeka if she can please load her presentation so long while I introduce her. Minette, I have left you right at the end, I'm afraid. Zandile Kubeka has 19 years experience working as a dietitian in the public sector. She's been based in the National Department of Health for the last 15 years, and her key responsibilities are under child nutrition, focusing on policy development, coordination, monitoring, and support within the broader context of maternal, neonatal child health and PMTCT. She's going to talk to us about some bottleneck analysis today and how she turned that into a quality initiative. Thank you, Zandile.
Thank you very much for this opportunity to be able to present on this platform. I will just go straight to it in the interest of time, which is limited. I think most of us on the call, by now we know that in South Africa, we have made some progress over the years in terms of reducing case fatality rate associated with severe acute malnutrition. We've also made progress in terms of reducing the proportion of deaths which are associated with acute malnutrition from around 30% in 2017 to about 24% in 2019 based on the available CHPA data. Just noting that we do have issues with the data because of its completeness and not representing all facilities that are reporting in the country. Despite some of this progress made, we know that severe acute malnutrition remains a significant underlying cause of in-hospital child mortality in South Africa. Based on this, and then also noting variations in case fatality rate and proportion of deaths across provinces and also within districts, we then undertook during the period of January to September 2023 a bottleneck analysis in collaboration with UNICEF. The objectives of this analysis was to understand the barriers and root causes to coverage, uptake, and quality impacting the prevention and management of acute malnutrition in children under 5 years. We also wanted to generate evidence-based cost-effective actions to improve quality, coverage, and uptake, and also to document some of the best practices in the selected districts. Just a quick run through the methodology. We worked in 6 districts in the Eastern Cape, including OR Tambo, Northwest, Dr. RSM, KZN in eThekwini, in Gauteng, Ekurhuleni, City of Johannesburg, and Tshwane. We applied both quantitative and qualitative data collection methods to do the analysis. We then applied the Tanahashi model, which is a participatory approach to analyze the performance of a health system to identify focused and context-specific actions to improve performance. The model also critically examines the main determinants of effective health service coverage, applying an evidence-based planning using a bottleneck analysis approach. So with this model, the quantitative data was entered into an Excel worksheet, which has a pre-populated formulas, which allows us to measure issues of coverage and quality. And then also from this, the bottleneck charts were then generated. The methodology applies 7 steps, including equity analysis, situational analysis, selection of tracer interventions, identifying bottlenecks and their root causes, identifying priority solutions, planning for quality, for equity, which then informs action planning, and then finally, monitoring of performance, which is done now on a quarterly basis. These are the key indicators for the tracer intervention management of severe acute malnutrition. We looked at 3 domains: supply, demand, and quality. And then the 6 determinants that we looked into were issues of commodities, human resources, geographic access, initial and continuous utilization, and effective coverage. Just very quickly there to look at the preferred indicators, we looked at issues of stockouts, training of healthcare workers, proportion of health facilities, and providing SEM management, assessment of severe acute malnutrition and classification, enrollment into care, and then also the proportion of children discharged as cured. So quickly on the overall summary of the key findings, there were various bottlenecks identified across the 6 districts, ranging from gaps in meeting the staffing norms, lack of adequate capacity building for healthcare workers, barriers to geographic access to services, stockouts of essential commodities such as RUTF, gaps in both the initial and continuous utilization of services, lack of harmonized systems to track effective coverage, and that's your SEM cure rates. There were also cross-cutting bottlenecks which were identified, ranging from leadership issues, coordination, and integration. Just looking at the root causes, I'll just go through quickly one by one. The issues around a supplementation program not being prioritized, lack of skills on forecasting for nutrition supplies by nutrition personnel, lack of ongoing capacity building on existing guidelines, no consequence management, staff structure not being revised, children located in areas far from health facilities, issues of transport costs, inadequate human resources to manage the desired coverage, poor healthcare workers' morale to undertake growth monitoring and promotion and also action, skills gaps in terms of anthropometric measurements, more specifically on measurements for height, and also the MOC measurements, lack of capacity building for the ward-based primary healthcare outreach teams and facility personnel to manage referral pathways, IMCI implementation not being prioritized, no clear directives for community healthcare workers to make appropriate referrals for children who are identified with malnutrition, and a key one on issues of data gaps based on the fact that we collect basically enrollment for those who are admitted within the inpatients with no data on those enrolled within a primary health care managed according to IMCI, and also no discharge data for children who are perhaps managed within the primary health care level. These are the examples of the bottlenecks charts which were generated after population on the Excel sheet. I will not go through all of them. The low percentages are the determinants which were found to have the widest gap. You can see they are different across the different districts. I will not go through each one of them. So there were also health systems and cross-cutting challenges. I will just mention them one by one. Issues of lack of supervision and technical support, no clear dissemination plan for existing guidelines, no lack of physical access to guidelines, incorrect data tagging in the DHIS, more especially for children presenting with comorbid conditions, the issues around confusion around what to record or report around primary and final diagnosis, the administration and logistical issues, issues of down referrals for children to PHC level, budget allocations not aligned to needs and geographic differences, decline in frequency of attending well baby clinics were identified as one of the key issues, quality and frequency of nutrition counseling, which is largely impacted by inadequate staffing, fragmentation of services, absence of job aids. The general population challenges included major issues around relapse for children who were previously admitted, linked to also persistent socioeconomic challenges, lack of integrated approaches. Under multi-sectoral collaboration is one of the weakest area, poor collaboration across sectors, more especially on investment in preventative interventions, inadequate sector budgets to address issues of malnutrition, food insecurity, and hunger, lack of transport with regards to movement of community health workers, They are required to cover vast catchment populations. Equipment issues, broken or limited anthropometric equipments. Coming quickly to some of the key recommendations identified through this process. There was a strong recommendation to formalize and upscale the training of healthcare workers. There was also a proposal to conduct a feasibility study on establishment of centralized long-term rehab centers per district, which will focus on issues of counseling for caregivers on nutrition, setting up food gardens, supporting access to social grants and other services. And it is believed that with this one, it could assist in us being able to know the effective coverage, more especially with the indicator on the number or proportion of children discharged as cured. Strengthening coordination and joint action, more especially on issues of prevention and management within the health department and across other sectors. Within health, the continuum of care is a big problem. Adequate resourcing or better resourcing, resource allocation and utilization. Integration of nutrition in pre-service curriculum in all institutions of higher learning, and also lastly, upscaling and prioritizing community outreach activities and empowering the ward-based primary healthcare outreach teams. This one is just for you to also have a look that we were able to also identify some of the best practices. I think for KZN, it has already been mentioned, the essential package of care audits, the same training for clinicians in Northwest. Key best practices identified: children who are linked with community health workers for follow-up after discharge, discussing the discharge plans with the caregivers, strong collaboration and referral pathways with other sectors, and most importantly, the involvement of local organizations and community leaders in community assessment and campaigns, monthly STEM committee meetings, training of clinicians by DCSTs, and also weekly monitoring. In Gauteng, death reviews, supervisory visit and clinic audits were identified as some of the best practices, and also data verification. In the Eastern Cape, Sarah Batman, they are partnering with universities to strengthen growth monitoring and promotion. I thank you very much. My apologies, my video does not work.
Thank you so much, Zandile. Lovely to see your face there at the end. That was fantastic. And sorry that you felt a bit rushed there towards the end. Thank you. We have just one speaker left for today. Minette, if you would like to share your slides while I introduce you. Minette is a familiar face on this platform, and we always do love your energy to take us into lunchtime. So Minette Coetzee is an associate professor and director of the Harry Crossley Children's Nursing Development Unit. This UCT teaching and scholarship unit is committed to building children's nursing in Africa for Africa. Minette is committed to building capacity in authentic ways that enable children's nursing clinicians, educators, and researchers from across the African region to articulate their best practices and contribute to building future generations of unapologetically excellent children's nurses. I'm going to leave it there and let Minette share her quality improvement initiative. Thanks very much.
Mandy, thank you very much. Sure, what a wonderful morning we've had of hearing just amazing initiatives and working with data. Can I apologize for that really long bio I sent? And thank you for that introduction. As we start, I cannot resist taking us back for a moment to our pediatric wards, yours or one anywhere in the country. This time, though, you're on the other side of healthcare. I hope you're all with me just before you head off to lunch. This is the time that you are there because you've brought a really sick child, maybe yours. They've been assessed. They seem to be better, but you've been told that you need to stay to stabilize the child, or even for some time longer. Ever so often, a nurse comes round to that bedside or cot, picks up your child's chart and says, has the child had anything to drink? How many wet nappies? How much urine passed? Oh my goodness, you have to think, was that 2 nappies you changed or 3? did he finish that last bottle? Oh, yes, he also had some juice from the cup. And then he wanted to go to the toilet. How many nappies was that? When we don't, a colleague of mine recently, Busi, said, what we know, what we haven't recorded is we don't consider it done. In these contexts where we have many children and few nurses and this rapid assessment of this absolutely vital process of managing hydration, this study, well, this piece of our work originated from there. Busi also developed an evidence-based practice protocol, which became central to the best practice project that we facilitated over 2 years with 7 teams across the country. Not actually across the country, across the subcontinent. That's what COVID helped us to do. And when you get stuck because you can't travel, then you just get onto the internet and do a wider thing. So we worked with these 5 teams and, well, we worked with 7 teams. 5 of them implemented this particular protocol. What we do realize is that we have many guidelines, tools and approaches and audit tools that we could and should use to support quality of care. But we, nurses and the rest of us, are all too often thin on the ground. One of the most staggering things of this project that we realized was the volume of care provided by teams. Across these teams, in a 2-year period, they provided care for more than 25,000 of probably the sickest children. 3 of these wards routinely recorded 50 to 60 patients with 3, sometimes 5 nurses on a shift. So the guideline that was developed by Busisiwe Jama that you've seen and a colleague, Adis Mlata, needed to include more than a flow chart of action. Really enrolling mothers in the monitoring of fluids required that they add some steps to manage this change outcome. These are the things we know that we normally need. One of the first things, though, and interestingly, something we completely underestimate normally on wards, is that every single child that's admitted to a ward needs to have a hydration assessment. What this flowchart helped us with is noticing who the children are that really need nursing assessment and care. The yellows, mums can be enrolled to do them. The other interesting thing was that if you do a really good assessment, there's some children that really don't need their intake and output carefully monitored consistently. So of course, there were other things that you need that you can assume. What do I see in the urine? A jug to measure with, and a simple intake and output chart for mums that I have to tell you, sometimes children filled in. They loved being able to fill this in. Participation. The team dashboards, we had committed really early on in this project that we would work with data. When we started, none of the nurses on these teams were working with data, really just because probably they had too much and it was all over and they didn't own it as their own. And a lot of the reasons we've already heard from other speakers before. So what we did was we developed a dashboard that they found engaging and they weren't monitoring everybody. So you'll see what this is really looking at how many children are assessed. Just a random selection of children, fill in the form. Actually, this one is the number of children assessed is on the following slide. This is how many children, what we're looking at, of course, is how many were not assessed. The 5 out of 6, this of 20, the 6 out of 20. And then the improvement related to documented and not documented. What this team of nurses, all these teams, our team and including them, found so just so encouraging was once nurses gathered their data and could see their improvements. Of course, we've heard other speakers say this before. Visible data shifts the way you think about what it is you're doing, especially if you can see the improvements and the improvements in your practice. At the end of this project, most of these nurses, in fact, none, I didn't hear any not speak about their excitement about data. After the program had completed, they continued with this enrollment of mums. All the wards said this made such a significant difference to their project. So that was our exit strategy, which you can see I'm saying in 1.5 seconds. The interesting things for us was how once they'd worked with their data and they knew there were things that they were doing that were shifting their practice and making it easier, they really started enjoying reporting on their data, telling the stories their data told. One unit in Zimbabwe told us that they'd managed to persuade the management at Mpilo Hospital to increase the beds in their ward. And for them, it was just, there's this huge sense of empowerment. This is what we do. We can track what we do, and we're giving you the numbers. I think it's probably time for lunch. So I'm going to say thank you for listening, and connect with us if you'd like to. And over to you, Mandy.
Oh, thank you, Minette. Sorry, I couldn't unmute myself. That is fantastic. And I just love the idea of the children, even if I think of the age of the children, those sort of 6 to 12-year-olds in the ward who just love being involved in carrying the food and whatever. I can imagine them enjoying their intake and output chart very much. So wonderful idea, and taking the load off our nurses. Always fantastic, inspiring stories from your unit. So thank you again. I'm going to ask Todeni, were there any specific questions you wanted to highlight on the chat? We have
Yes.
2 minutes left. Go ahead.
Okay, yes, we have one from you directed to Zandile. You just wanted the concept of teaching caregivers how to grow, cook, and prepare the nutritional food for children comes up again and again as a cost-effective recommendation to save lives. What was your strategy to roll out this particular intervention? This is to Zandile. And then there is another one that they want also to Zandile by Ute. On your recommendation, I'm not seeing much bigger focus on outpatient management of SEM with Raft. Maybe she can take these two together, then we can, and then there's Prasha. And this one is from Lodley. Did you also audit the use of non-pharmacological measures? I think either Zandile or Prasha can start.
I think Prasha did answer that in the slides that followed. So she has stepped out to attend another meeting, but she did tell us her non-pharmacological methods, and she answered in the chat to say they need to work a bit harder on it. The uptake only increased to 50%, but thank you for that question, Laurie. Zandile, are you able to tackle any of the two questions?
Oh, yes, definitely. And thank you, because then it allows me just an extra few minutes to unpack. The 10 minutes doesn't allow you to actually do this. The one that you raised, Mandy, is a critical one, and I will safely say this is still at the recommendation phase. It might be happening in small pockets in some of the districts or sub-districts, especially on growing their own home food gardens, but not fully at scale. But the issue on preparation of nutritious foods, it's something that which we encourage really districts to try it out in various sentinel sites and come back and share with us how they find this to work. So it's one of the key recommendations that which I think as we digest the report, it's something that must be taken up at a sub-district or local level. With regards to the one by Prof. Ute, it's a very critical question, and I think it talks mainly in terms of gaps that we're seeing in terms of implementation of IMCI. We must say that it's coming now and again that, IMCI is not implemented optimally as it should. I will just give you a few examples that, there are provinces and districts wherein all children who come in with a severe acute malnutrition with or without complications, they are referred directly to hospital level, wherein ideally children without complications, they should actually be managed within the primary health care. So upon engaging with some of the districts, we do learn that the capacity within the primary health care level to manage the children is a serious concern, and some also referring to the fact that if all children were not referred to hospital level, they would have seen more children dying due to severe acute malnutrition. So it's about, making IMCI work within primary healthcare level. You saw the slide where I indicated that about 8% of children are reported as being enrolled into care. That does not include children who are managed within a primary healthcare level where it is happening. And that is largely also because of the gaps that have been identified within the primary healthcare level to be able to manage these children. Hence, we see only a report within our national indicator data set on inpatient management. There are also data gaps wherein for primary healthcare, the two indicators that we collect, there is a SEM incidence, which is all the new cases that are assessed within the primary healthcare level, but we cannot tell whether the child has been referred or not referred, but we know anecdotally that most children are referred to inpatient management. So the system has not incorporated enrollment as those children who are managed within the primary health care. That could have maybe given us more idea in terms of, how many children overall are enrolled into care, both outpatient and inpatient. So we can't tell, although it might be happening in pockets in some of the districts. So they need to look into how do we build capacity to ensure that, IMCI is utilized optimally, because the guidelines are there. The chart booklet is comprehensive enough to for clinicians or primary healthcare nurses to be able to manage children at that level.
Thank you very much,
I've answered your
Zandile.
question. Thank you.
Thank you so much. I'm going to wrap up the session. My head is spinning with ideas. So thank you so much to the 8 speakers who shared their innovations of such variety and with such enthusiasm. We really appreciate the time you've taken to share. A last reminder, please join the AGM at 1. This is the program that I've shared on the screen. We do need to meet quorum to elect the new executive of the Child Health Priorities Association. And we would love your thoughts on the idea of a virtual versus a face-to-face conference next year, as well as any volunteers who would like to hold the conference in their area. So we will see you back here at 1, and thanks again to everybody for a fantastic and very inspiring session. Bye-bye.